Dr. Ramish Rafay. I'm a PGY2 here at Advent Health Internal Medicine Residency, and we do this journal club every year. PGY2s do it. I'm gonna kick it off. We're gonna discuss this article. It's about the use of simvastatin in addition to standard of care in patients with cirrhosis who have survived a variceal bleed. So first, I would like to say simvastatin, it might be a little counterintuitive for some of us because statins are some of the first drugs we usually stop when somebody has anything, any boohoo to the liver, anything that happens to the liver, statins are the first thing we stop. So for it to be added to the standard of care, it's a little bit counterintuitive. But yeah, so let's go into some background of the disease burden. So cirrhosis it has a very huge disease burden. Every year, millions of people get diagnosed. I think there was a study done, 2.05 million cases and 1.47 million deaths from cirrhosis just 2019. And this was based on the global burden of disease study. It's a very significant issue. And the problem is that like heart failure, which is a very, I like to call it as a high visibility disease. It has like multiple trials on GDMT therapies that can prolong a patient's survival, prevent remodeling of the heart, but there's no equivalent therapy for someone with cirrhosis. There are some like drugs like Resdefra, what was it called, Resmetirom, I think, and then GLP-1 agonists, but they're not seen to like prolong survival. They do help in the early stages of before the person develops cirrhosis, so to speak, if they have hepatic fibrosis. So there's no like once you develop that cirrhosis, there are no like disease modifying therapies like you have in heart failure. So, and then the leading etiologies for cirrhosis, you have alcohol related cirrhosis. And then a newer emerging one is the MASLD, thanks to the rising prevalence and incidence of diabetes and obesity, and especially in the US, MASH and NASH, these are overtaking alcohol now at this point. So yeah, and then compensated, now let's talk about the mortality differences here a little bit. As long as a person is compensated in their cirrhosis, and by compensated, I mean they might have varices, but they're not bleeding. They have never had hepatic encephalopathy. They have not had any kind of ascites. As long as they're compensated, they have a reasonable, they have high mortality compared to the general population, but it still ranges in the 10 to 20 year figure. But as soon as you develop a decompensation, that is a life-altering event. That is like, you ask any hepatologist that's like our goal is to not get to that point to develop any kind of complication. And the next slide will illustrate why, because the mortality dips dramatically goes up, and their like lifespan dips dramatically as soon as they develop a decompensation. So let's go to the next slide. So here we have this picture, this table from the diagnosis and management of cirrhosis. This is a JAMA article, and if you look at this, these are all the complications of all the decompensations associated with cirrhosis, and each one you look at their survival. So with a hepatic encephalopathy, the median survival 0.95 year, close to just 1 year, okay, like 2.5. Ascites median survival around 1.08 year. Variceal bleed, it's not even in years. They're saying that 17% mortality at 6 weeks. So that's pretty significant. Hepatocellular carcinoma, less than 20% of them will survive up to 5 years. So it's like these, like you can tell as soon as these people develop a decompensation, the clock starts ticking and they have really like short lifespans. So there are no therapies available in this group that has shown definitively to prolong their lifespan or decrease mortality, so to speak. So yeah, now we come to the role of statins. Statins, traditionally we think of them in two ways. Either they work for lipid lowering, or they are used in cardiovascular events. Somebody has a plaque rupture, you want to stabilize that plaque. If they have like a coronary event, you want to give them statins to make sure that the plaque doesn't like rupture more or cause further worsening. But why do we use them in liver injury? Like why this sudden shift in using them in cirrhosis? Well, the reason is that they have been found to have a, how should we say, their effects extend beyond just the lipids, lipid lowering effects. This phenomenon in pharmacotherapy is known as pleiotropy. A drug has like a wide ranging set of effects that is broader than the one thing that we use it to treat. So we can go, I guess, further. Yeah. So here, this is also an image that illustrates which segments of the cirrhosis the statins have been shown to affect. So it has been seen in experimental studies to reduce the activation of stellate cells in the liver. And these stellate cells, they are responsible for the excessive fibrosis and collagen production and just changing the architecture of the liver when it comes to cirrhosis. And they also decrease inflammation as well. So that's the mechanism, and that is what generates this hypothesis that they can be therapeutic in patients with cirrhosis. Now, why do we want to use this specific drug to prolong survival or decrease mortality? Like, where does that data come from? So there was a study done. So these are two studies. The first one, if you look at it, it has a long name, but the trial is called Bleeding Prevention with Simvastatin, PLEPS trial. So basically what they did was they took patients who had cirrhosis, Child-Pugh class A or B, and we'll talk about this Child-Pugh classification as well. Class A or B, who had a variceal bleed, and they thought that they could use simvastatin to reduce the risk of rebleeding in these patients. Well, that didn't happen. They could not reduce the risk of rebleeding. But one of the secondary outcomes that they were looking at was mortality. And they stumbled on it, I guess, accidentally, that in this study, it reduced these patients' mortality. And so there was a survival benefit for these patients, just in Child-Pugh class A or B, but not in C at 24 months. So the study that we're going to be looking at now attempts to replicate the results of this. Like that is their main goal, is to see whether it improves survival at 4 months or not. Patients who are randomized to simvastatin after having a variceal bleed from cirrhosis, does that improve their survival or not? That's the goal. The study that's underneath it, simvastatin and rifaximin, this is called the Liver Hope trial, and unfortunately, it did not show any differences in mortality. So conflicting results there, but I just thought it would be good to mention it. Although I would like to point out, if you look at the patients that they included in their study, they were Child-Pugh class B and C. These are much sicker patients. So I don't know, just want to point that out, I guess. Anyways, so moving on to the objective. So the main objective of this study was to see whether adding simvastatin to standard of care in patients who have had a variceal bleed, standard of care being carvedilol and band ligation of the varice, does that improve their long-term survival beyond just the standard of care itself? So that was the main objective. Okay, any questions so far? We're following? Yep. Everyone's following? Okay, great. Okay, moving on. So let's go into the method section. So this was a single center, open label, randomized controlled trial, and it had a superiority design, right? They had patients with cirrhosis, Child-Pugh classification 5 to 12. So basically what this range means is A, B, and the less sick segment of the C classification were included. So Child-Pugh class C was also included, but I would say on that spectrum, some of the less sick people were included. And they were assigned to either receive simvastatin 20 milligrams once daily or no drug in addition to standard of therapy, carvedilol and band ligation at day 5 of variceal bleeding. And I can also mention here the way they controlled the variceal bleed was terlipressin 1 gram Q6 hours and then as needed blood products and then band ligation. And carvedilol was started at 6.25 up to 12.5 for patients with ascites, because that's the max you can give for patients with ascites. They're at high risk of hypotension, you know, like dump their blood pressure. And then if they don't have ascites, then they went up to 25. I didn't mention that here, but anyway, important to remember. And the primary outcome they were looking at was the all-cause mortality at 24-month follow-up. So notice how, like, compared to the previous trial that was looking at the rebleeding risk, the one I mentioned, they took somewhat the same design and just changed their outcome. They said, okay, we stumbled on this outcome. We couldn't stop the rebleeding. May as well test out if this like it actually increases the all-cause mortality at 24-month follow-up. There was no funding agency. No company was involved. And actually, this is interesting because it kind of goes into one of the limitations of the study. So we'll talk about it a little bit. And the inclusion-exclusion criteria, patients with 18 or more years with cirrhosis, any etiology, presented with variceal bleeding, had achieved endoscopic hemostasis, no failure to control bleeding. So what they excluded was someone who needed repeat endoscopy to control their bleeding. That was counted as a failure to control their bleeding. And who required TIPS procedure, or who already had a TIPS procedure, because these are very, very sick patients. And then, like they mentioned, CTP score more than 13. Again, that's like the end of the class C Child-Pugh score. So anyone who had hepatocellular carcinoma, anyone who had AKI, or any contraindications to statins, and isolated gastric bypass, those they included. So it was a very, very clean population, I suppose, some like 18 years of cirrhosis, just variceal bleed that was controlled on the first endoscopy. And then this is like a schematic of the design. You can see they took 268 patients, randomized one-on-one, intervention group 130, control group 138, and then they went down and looked at the primary outcome, transplant-free survival, secondary outcome also mentioned here, and then there were safety outcomes as well, hemostatin adverse events, and they reported that as well. One thing I have to speak about is the randomization. It will come up, but they didn't do like the block randomization that you would expect with larger trials where they divide the groups blocks and then randomize on that. They just did like a coin flip in R, a fancy kind of a coin flip. There's R is like a programming language that they did a run if function, and whatever random numbers they generated, they used that to randomize. So also a limitation of the study, but we'll go into that later. Yeah. So yeah, let's talk about the Child-Pugh scoring system. So usually we do two scoring systems. There's the Child-Pugh, and then the one that most of us have probably heard of in the hospital is the MELD sodium or the MELD scoring system, right? So the Child-Pugh scoring system was originally conceived of in the 1960s to predict mortality only in patients with TIPS. Okay, long-term mortality in patients with TIPS. Then eventually it started getting expanded into like being used for deciding what the like perioperative mortality for patients with cirrhosis would be for other procedures as well. So if you like attend Dr. Santos's lecture on like perioperative mortality, he mentions this score, like in patients with cirrhosis, whenever like they need to be cleared for surgery, this is the scoring system that comes into play as well. And the thing I have to emphasize, it's a more long-term. It gives a more long-term outlook and prognosis for the patient, whereas the MELD sodium is just for 90 days, 90-day mortality prediction, okay? Which is why if somebody has acute on chronic liver failure, if their cirrhosis is getting really bad and you want to get them on a transplant list, the prioritization is that MELD sodium because it predicts the 90-day mortality. And as their score goes up, they go up on the priority list as well. On the like, it basically decides who gets dibs on the liver transplant, I guess. I'm sorry, that was non-serious to put it. But yeah, so the scoring goes from 5 to 15, divides the patient into three risk levels. A is 5 to 6, B is 7 to 9, and class C is 10 to 15. And this score is categorical. It has albumin levels, and then INR, and then what's the other one? I think the total bilirubin. And the two clinical things it has is encephalopathy and ascites, presence or absence of ascites, whereas the MELD sodium is a purely lab-oriented score. It's based just on the labs, liver synthetic functions. So this is the scoring system they use in this study because they want to look at the long-term outlook of these patients when we're talking about in years. Okay, so methods continued. So the dosage of the medication, the intervention arm was started at 10 milligrams per day for 2 weeks, and if tolerated, they increased it to 20 milligram per day. The reason for this is that one of the trials I mentioned earlier, the liver hope trial, the one that did not show any kind of benefit, one of the things they saw was that the 40 milligram dose was associated with an increase in risk of rhabdomyolysis. Patients were not able to tolerate the 40 milligram dose, increased risk of elevated transaminases, increased risk of acute on chronic liver failure. So they, like this study, they kept a ceiling of 20 milligrams per day for these patients. And they even like tapered it up, like they went up, titrated it up, not just like start the patient with the 20 milligrams. So and then the standard of care I just mentioned here, I've mentioned before as well, carvedilol 6.25 up to 12.5 in those with ascites versus 25 in those without ascites. And then the monitoring and the follow-up, there were monthly follow-ups for the first 3 months, and then they were followed up at 3-month intervals. This was done through phone calls. If they missed their appointments, they call them. And what else? I think that's for the randomization I just mentioned was a simple randomization, run if function and R, basically a coin flip. And this has its disadvantages as well. It can introduce some unconscious like bias. You might end up with, and it has some bias. Actually, we'll go into like the randomization and see like how there are some issues caused because of this. But yeah, well, simple randomization, not block. And so these are the baseline characteristics of these patients. Little hard to see, I don't know, but yeah, I can zoom in. Yeah, here we go. In most of these patients, the etiology was alcohol. So these patients had alcoholic cirrhosis. The second most common etiology was non-alcoholic steatohepatitis, and then hepatitis B and hepatitis C. Now, others, I tried looking in the supplementary material of the study. I tried looking up, like I read it from up top to bottom. I could not find like what these others etiologies of cirrhosis were. Was it autoimmune hepatitis? Was it primary biliary cholangitis? What was it? They didn't mention that, but just put it there. And then this is what I was talking about, like the randomization issues. So if you look at this is something we can talk about again in the limitations part of it as well. But if you look at the alcohol section, there are 63 people in the standard of care, 66 in the standard of care plus simvastatin. That's good. That's fine. They're like close enough. But if you look at the segment of active alcohol use at the time of recruitment, look at how like only 30 people in the standard of care, whereas 43 in the standard of care plus simvastatin. That's, I would say that's pretty like, it's a big difference for like a small sample size to have. I think it probably happened because of the randomization, the way they did it, like simple coin toss. But yeah. Oh, sorry about that. Then the outcomes that were transplant, primary outcome was a transplant-free survival at 24-month follow-up. And the secondary was an all-cause decompensation, incidence of rebleeding, new or worsening hepatic encephalopathy, and acute and chronic liver failure. So yeah, go into the statistical analysis. They did this in order to have like an 80% power or 80% chance of detecting a true or real difference between the treatment and control group, while also accepting a minimum of 5% risk of falsely concluding that there was a difference when there isn't one. It was estimated that they would need 54 patients. So these statements that I'm making right now, the 80% chance of detecting a true difference, this is the power. I'm referring to the power of the study. And the 5% risk of falsely concluding this is, I think, the risk of the alpha, basically. And so they needed 254 patients, they said, to be able to detect this with 127 in each group. But they also estimated that some of these patients would drop out. So they increased the final sample size to 268. And the p-value they selected was 0.05. Both intention to treat and per protocol analysis were performed, and the primary outcome was analyzed as a time to event variable and the hazard ratios. They did hazard ratio calculations for these. Let's go to the. Does anyone know what everyone knows what intention to treat and per protocol analysis is? Familiar with it? Okay. Any questions so far? No. So the primary outcome. So in the primary outcome, overall, they did a survival benefit. They did see a decrease in mortality at 24-month follow-up. And yeah, so the hazard ratio came out to be 0.48 for these people, which is less than 1. And the confidence interval 0.29 to 0.81, which excludes the null value. So this is significant statistically. But when they stratified it by the Child-Pugh classification, what they found was that the main benefit was in the Child-Pugh class B group, and not so much in the C group. What was a little bit surprising is they don't say that there's no benefit in the A group either, which is a little bit like why is it affecting only the B group? I think but confidence intervals are wide. I think it could be, we can discuss this in limitations again, but I think it could be because of the sample size as well. We don't have, this is somewhat of an underpowered study. If you look at, for example, if you were to look at other trials such as the heart failure, like I mentioned, they're the gold standard. Look at heart failure trials, enalapril versus Entresto. I think it's the Paradigm HF, it's called. They have in each arm, the treatment and the placebo group, they have 400 people. And so their confidence intervals, and they are randomized and blinded. So they are very certain, their confidence intervals are very narrow, and they're very certain about their treatment effect. Over here, it wasn't blinded. It wasn't, the sample size wasn't big enough, which is why we're seeing these wide confidence intervals. So yeah, but with this study design, what we saw was that the main effect was in the Child-Pugh B group and not so much in the A or C. And yeah, so the primary outcome was achieved, and then yes, we can go into secondary outcomes. And then all-cause decompensations, they did not show any significant differences except for spontaneous bacterial peritonitis. It's not really showed over here, but that was a new incident, a new onset worsening ascites or spontaneous bacterial peritonitis. They were less frequent in the simvastatin group compared to the standard of care group. So yeah, but again, as you can see, these are wide, really wide confidence intervals. It means that just for these particular outcomes, there's not enough participants. So we need to if this study were to be performed again, it would have to be with a lot more people in both treatment and intervention group for these confidence intervals to shrink and for us to be more certain about these results. Yeah, so it. And this was the incidence of the adverse effects that they checked as well. So the discontinuation of Simba, there were 17 people in the Yeah, in the standard of care group. Oh, sorry, in the. Yeah, there we go. Yeah. Yeah, so a number of people actually stopped taking the simvastatin. As you can tell, 17 of them. And then the main reason they did was body. That was the main issue. And yeah, some of them, there was one patient who stopped it because of epistaxis. I don't know why, but yeah. The main issue was body aches. And yeah, moving on to the next. So just like up till now, what do we think are the strengths, I suppose, of this study so far? Do you have any? Anyone want to take a jab?
Yeah, it's good mortality signal proof.
Oh, yeah.
It's good. Also, there is randomization as well. Have controls. There is controls. Also, the two groups, it's an add-on therapy. So the first group has the standard therapy.
The other one
added
add-on.
something with the standard.
Yeah.
So you know that it's addition. And this is what comes.
Now we come to the limitations. I think that's where everybody will have a lot to say. So what are the limitations of this study?
It's open label.
It's open label.
Single
Sample size,
Those are
and,
there.
sample size,
Sample size.
yeah.
So just want to add, the reason it's open label is because they mention it in their paper that they wanted to have a placebo that looked exactly like simvastatin, but because they weren't funded, they couldn't get it. So there was no way to have a placebo that looked exactly like the simvastatin pill and blind, so everybody knew who was taking what. So it's like a very.
As a strength too, they have good number needed to treat. I think it's 8.
I think, yeah, I was like.
That's a, and I tell you guys, that's another number 10 rules, right? If the number needed to treat is less than 10, meaning that have to treat 10 patients to get your primary outcome, that's pretty good. That's very good, right? And you guys know how to calculate the number needed to treat? Come, a senior, explain it to them. Explain to the interns how we calculate the number needed to treat. Yeah.
Yeah. So
Or it's,
One
But-
yes,
risk reduction.
1 over 8.
You calculate the absolute risk reduction. You get it by dividing, subtracting the number of adverse events in the control group and then from the experimental group, and then you divide, absolute risk reduction by 1, and then you get the number needed to treat.
1 divided by that. 1 divided by the absolute risk reduction. And if you do it in terms of a percent reduction, it's just 100% divided by the percentage risk reduction in the treatment versus the control group. That saves a step of converting into a decimal point. Good.
Any other limitations? Open label, randomization wasn't blocked.
Looking at the forest plots, when you look at the overall, as opposed to teasing out the severity by child view ABC, you see that it falls on the line of no effect, the overall.
Mhm.
So I'm not sure why it kind of canceled out. Influence.
Oh,
Right in the middle. The overall.
you,
Yes.
Hmm.
Right.
The top.
Yeah, the first one. Well, it's a little.
are you,
I think it's just to that.
it's to the left, the overall is the lighter line.
Yes,
The null is,
The one is the fine line,
yeah, the one.
the dotted line.
Or the dotted line, you probably can't see the dotted line.
It is
because it's
supposed to-
small, Dr. Jones. You see the dotted line.
Yes,
on the
so-
right.
This one right here.
Yeah.
This is the, yeah, this is the null, and this is where it crosses.
I don't
Like-
see it.
is the dark line maybe the superiority threshold?
I think so.
I
Yeah, that is, yeah.
Because it's less than 1. so
Yes,
that's why,
that's right. The superiority
Yeah.
threshold. That was the threshold. Yeah.
And they made it so faint.
Also, sick patients were excluded as well because we don't have a
Yeah.
lot of type C. Also,
I think the other limitation is that the main etiology they choose was the people are alcoholic,
Yeah.
whereas in a country like suppose the US, it's mostly been driven by NASH and the NASH. So
Yeah.
and being a single center and being in a country, it's in
It
India.
was in India, yeah.
So the more homogeneous population, so apply these results to a more heterogeneous population like the US would be
And
difficult.
The confidence intervals are very, very wide as well.
Yeah.
I mean, like for group A, for trial PUA, it goes from like 0 point something to almost 2.
It's like all
So
over
it's
the
like
place.
super protective or super harming. So it's very, very broad. Yeah.
That's probably, I think, probably because of the decreased power of the study. and
Yeah, yeah.
Less number of participants.
I was a little concerned that a lot of the patients were still actively drinking and or
There are a
which
lot
would
of
affect transplant.
Transplant, yeah.
Which would affect their ability to be eligible for transplant, right? They have to be like 6 months alcohol-free in an approved program. And the other thing, there was another thing I wanted to say about the active alcohol and transplant. Oh, compliance, like how I was a little concerned about how compliance was measured at 3 months, particularly in the active drink.
So,
I'm not saying
yeah,
they would tend to be not as compliant. How will we
Ah.
objectively how were they how were they objectively identified as actually taking the drug? It's not like
That-
you can measure simvastatin levels. This is just like, are you taking it? Yes or no? And they're intoxicated and they're telling you, yes, you're taking it.
It's just based on their follow-up
Objective, yeah.
objective. So, yeah, that's true. That's a good point. So, yeah, the limitations, no blinding means that the results are very susceptible to your observer bias. And the simple randomization, no block randomization, which means there's some imbalance in the groups. Other etiologies, I couldn't find what they meant by all these other etiologies. Again, are these autoimmune? Are these primary biliary cirrhosis? That like what are these? They didn't mention that. And single center study in India, low representation of MASH cirrhosis and limited generalizability.
One other thing I would say, it would have been nice to see cardiovascular risk as an
Yes,
independent risk factor.
independent risk
because
factor.
We're attributing it to the statin.
Starting, yeah,
the benefit from the cirrhosis
Yeah.
and not knowing the cardiovascular
Cardiovascular.
risk.
yeah, that would have been too. Yeah, that's a good point.
What's the major etiology for cirrhosis in that case, like in their patient?
It was mainly alcohol.
Alcohol.
Infection was the third.
Third.
So mainly alcohol, then steatohepatitis, and then hepatitis B. So, but yeah, and I think the last thing I would say with the wide confidence intervals, perhaps it's a little it's underpowered. If they had recruited more patients, and perhaps if the treatment effect was a bit stronger, then we would have been more certain about whether it does whether these effects are real or not. So yeah, but I think it is an easily replicable study if it was done in a place like the US in a multi-center setting with proper blinding, proper randomization, large patient population. I think we could definitively be able to say whether simvastatin has a survival benefit or not. But yeah, so and then this is a meta-analysis that includes this study as well. I just thought it would be a good idea to add this. It was published in July 2026, so I think a few months after this study was published, and yeah, it shows that so it basically shows that the overall mortality they added. I think they took 7 studies, and then they saw that overall mortality was significantly lower in patients who received statins. But they also conclude in their meta-analysis as well that this is more like we still need to do further RCTs, larger RCTs with proper randomization to definitively say whether there's an effect or not. So yeah,
I'm sorry, I can't see the print. Was there a p-value?
There is a p-value, yes.
0.002. I don't know. And the heterogeneity is 0%.
Yeah, so,
There's no way. Like,
so we can't believe it. Okay, never mind. Forget about this. Ignore this.
So I guess and then the main thing, so guys, when you're second years, when you're PGY2s, you have to do one. Good, thank you, Ramish. I'll give you my feedback, in person.
Dr. Ramish.
Yeah,
I'm in trouble. You guys, if I go missing, you'll know.
good detail background information. But when you guys, PGY2s are expected to do a journal club presentation, and we have a journal club template on Doc Launcher that's very detailed, right? And it shows you exactly how to put together your presentation, okay? And you sit with me and discuss it before you present, okay? So you have to do one. When you're PGY2, you do one journal club in your PGY2 year, okay? One journal club each.
I have one thing to say in terms of applicability. How applicable is this study in our setting, real world?
And that was my next point.
Oh, okay,
Yeah,
sorry.
no, it's okay. That's very good. We think alike. That great minds think alike, Dr. Jones. And we always have to ask ourselves, based on what Dr. Rafay presented, are you going to recommend simvastatin? 10, start with 10 a day and then 20 to your patients with Child-Pugh scores, A, B, and early C, to decrease their mortality, then 24-month mortality. Do you feel confident enough based on this data and this trial? So, and if so, why not, or why yes?
I think it's still early to prescribe,
Mhm.
but the study shows like a good signal for more research to be done regarding mortality. Yeah, we would like to wait for more papers.
Especially
More work.
in metabolic dysfunction associated, to hepatitis patients, not just alcoholics, right? I think
I would argue that I would say you can recommend it. I mean, the reason is cirrhotic patients, they don't have a lot of options to begin with. So anything that shows any kind of small benefit, it's useful. Simvastatin in this study showed that it's safe. Also, there was not a lot of adverse effects. It has a lot of cardiovascular benefits in a patient population that is already high risk. So I feel like, sure, the data is not excellent. Definitely, this meta-analysis is also probably fake. Not fake. I mean, it's a real study, but it's probably the methodology is probably questionable. But I feel like we have enough safety signal, enough benefit signals that for a almost desperate patient population is reasonable, I think.
I think it should definitely be considered if they have a concomitant reason to be on
Yeah.
statin, like cerebrovascular disease or cardiovascular. Right, kill two birds with
Yeah.
one stone.
But then the study did exclude the people who were already on it for other reasons, right?
Yeah, people who are already on it are working.
Right, but I guess in real life, if we have another
Yeah.
for it, I think it's reasonable to consider.
But if anybody is interested, I think this meta-analysis could be repeated, same title, because most numbers doesn't make sense. Also, the dash in the